Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education. Hi, Karen. How are you?
I'm great, Anne. How are you doing?
Good. So let's podcast today. So my first topic, my article for today is on breastfeeding during pregnancy. And it seems like these articles are sort of far and few between. So I'm always excited when I see something written about this topic. This article was a meta-analysis entitled Effects of Breastfeeding During Pregnancy on Maternal and Newborn Health and Breast Milk Composition. And the authors are from Turkey, Özlem Sinan and Dandu Kurnaz. And this was published in Midwifery, the issue 149, just this year in 2025. So this meta-analysis evaluated the effects of breastfeeding during pregnancy, maternal and newborn health outcomes, and also the composition of breast milk. So just for some background, the authors mentioned that the recommendation to breastfeed for 2 years increases the risk of women ending up pregnant, breastfeeding during a pregnancy. And they cited a 2008 study in Egypt of about 2,600 women that found 25% of women reporting breastfeeding during pregnancy. The study that they quoted for the United States was from 2000, which had an estimate for breastfeeding during pregnancy of about 5%. But I think that number might be higher from some more recent work.
Is that 5% of people who are breastfeeding get pregnant while they're breastfeeding?
Women who reported ever doing both, being pregnant while breastfeeding.
So of all the women in the population.
Yeah. Looking at women who have given birth. Yeah. And then in India in 2002, 1/3 of all pregnant women were breastfeeding at one point. So we've generally thought of breastfeeding during pregnancy as generally being safe, pretty natural, right? As this naturally happens, which should be safe if it's natural, maybe. I don't know. I guess I haven't thought about those two things together.
We evolved with this.
We've evolved with this, right? And we've thought of it as not really being associated with an increased risk of miscarriage, although there was one study that was done in the US that was published like 2019 that indicated that there may be an increased risk of miscarriage if the child is exclusively breastfeeding during pregnancy, meaning is not taking solids yet. And in this study, the researchers were able to distinguish this group from those who had short interval pregnancies, meaning that because they weren't taking solids, it doesn't necessarily mean that these mothers were pregnant within the first 2 months after giving birth. So generally in this meta-analysis, what the authors wanted to accomplish was to answer the following 4 questions, and they found 13 studies that met their inclusion criteria. The first question was, does breastfeeding during pregnancy affect the general health of the mother? And does breastfeeding during pregnancy affect fetal and newborn growth? Does breastfeeding during pregnancy affect breast milk characteristics? And does a country's level of development influence the health effects of breastfeeding during pregnancy? I'm going to address the last question first, which was about the level of development or income/resources on the health effects of pregnancy. And yes, that makes a difference. So the developmental level, or I guess I would say income/resource level of the country, determine the extent to which maternal nutrition had an impact on milk quality, with a greater impact among those who, really had difficulty getting enough nutrients in. So what they found is that in these lower resource countries, women were at higher risk for iron deficiency, B12 deficiency, and other micronutrient deficiencies. And then, of course, that impacts milk quality because those micronutrients are not created by the cells that make the milk. They're actually, using the maternal resources to transition into that breast milk. And we don't really see that impact on milk quality in high-income countries where nutritional deficiencies are just not as common. They found that in general, breastfeeding during pregnancy did not influence the likelihood of miscarriage or preterm birth, although in general, the rates of miscarriage and preterm birth are lower among women in developed countries who breastfed during pregnancy versus those who were in low-resourced countries. One study that was conducted in low and middle income countries reported that breastfeeding during pregnancy increases the risk of low birth weight and intrauterine growth retardation. And then another similar study that was done in Italy demonstrated that breastfeeding during pregnancy didn't impact intrauterine growth in developed countries. So the difference was, again, the resources in those countries and how it impacts low birth weight and IUGR. The authors point out that because of this discrepancy based on maternal nutritional status, it's important to assess the individual's health, especially regarding nutrition, to prevent complications like low birth weight. And I think that, that term orthorexia, have you heard orthorexia? Like people who are very, very concerned about the quality of the food that they eat and, whether it's contaminated or where it's grown and it has to be super healthy, which can lead to people sort of not eating a good variety of food and maybe missing some micronutrients. I wonder if that happens in this country. But generally, it's thought that if women are eating well and gaining weight well, they shouldn't have issues with low birth weight or IUGR.
I think that's super interesting. And also, it makes me wonder, I've seen a fair number of patients who have a history of eating disorder, and that impacts their breastfeeding in a number of ways, some of which is related to food restriction. And so those people might be at higher risk as well.
Right. Thinking about eating disorders. My general approach has been, since looking at the literature on this, that if someone is breastfeeding during pregnancy, to just say, hey, it's probably a good idea just to meet up with a dietitian, because many of my patients will contact me and say, hey, I'm pregnant. Is there anything I should know about breastfeeding during pregnancy? And that's one of the things I recommend, even though I don't know how much dietitians know about nutrition during breastfeeding specifically. I think that they probably learn more about pregnancy than they do about breastfeeding.
Well, I mean, just to go down a tiny rabbit hole here, I will say there's very basic guidance that women who are breastfeeding need 500 extra calories a day. And I would just say I always am fascinated because the way I think about how much a baby needs to eat, you can do the calculation of how many calories are required and how much is in milk, and that is where that number comes from. And so I always just say to people, if you're dual feeding breast milk and formula, then it's a ratio of that number. If you're feeding twins, it's twice that number. So it's just not a made up number. There's a place that caloric need comes from, that sometimes I have patients who are, pumping with massive overproduction. And I have seen that, sometimes that is impacting their caloric needs. And so my only concern with the dietitian is not necessarily, taking that cookie cutter number and not applying it to how much milk is this person producing?
Right, exactly. And trying to be able to figure that out. Yes, exactly. That's a really great point. And so both you and I know that breast milk production tends to go down in pregnancy. I think it's uncommon to not see it go down. They found one study that determined that milk production decreases the most in the second trimester, which I thought was really interesting. I didn't know the evidence on whether it was first or second trimester. It makes sense that it would be second trimester because that's when the placenta is more highly developed, has more hormones, and there's probably a greater impact on the tissue growth and tissue remodeling during the second trimester.
Well, and I just think of as the estrogen, there's those charts of what your hormones are doing during pregnancy. As estrogen increases, that is likely to push down milk production.
Right. Yep, exactly. So, and I think clinically, I agree with that. When I think about my patients calling me or sending me a message saying, hey, I'm pregnant, and don't need to know anything. And I'll ask, did you notice a drop in your production yield? And they'll say, no, I haven't noticed that. I just noticed like a lot of breast pain. But then they may contact me like 2 to 4 weeks later and say, oh, my production is really down now. Now what do I do? What can I take to increase my milk production during pregnancy? And of course, they can't, right? Like we don't want to recommend like medical
Yeah,
programs
I mean,
like that. I mean, that's silly. Yeah.
of course, it's a challenge. And so it's part of the, prenatal counseling or the later in breastfeeding counseling I give people of like, hey, your fertility is more now that you're not
Yeah.
exclusively breastfeeding all around the clock. Let's think through what would it mean to you if you had another pregnancy and how that would impact your goals for breastfeeding.
Right. Right. One study found that breastfeeding during pregnancy was associated with reduced maternal weight gain and lower hemoglobin levels. And in 2 studies, there was an increased risk of cesarean birth, which I thought was interesting. Um, and then when they looked at the effect of breastfeeding during pregnancy on the composition of milk, they didn't really find anything. So they couldn't answer their own question because there just wasn't enough data. We do know, you and I know, that milk will transition to colostrum when the baby's born. And I've always been I've always been amazed at the fact that these babies, they lose the normal amount of weight, right? That one would expect any newborn to lose. Um, their milk comes in readily, and I tend not to see like a delay in secretory activation in these people who have continued to breastfeed, but they do lose weight. I mean, it just goes to show you that babies are really waterlogged when they're born, and that, to not lose weight, unless they're not waterlogged at all, and there's like oligohydramnios, there's the weight loss is just physiologic so much because they are peeing like racehorses after drinking a ton of amniotic fluid before they gave birth.
Well, and also, they just don't eat that well in the first 2 days. They're asleep and they're nibbling, and then they're
Right,
asleep, and then
right.
they're
So even
off.
if the
Like,
milk is there, they may not take it, is what you're
yeah,
saying.
they're slackers.
Yeah, they're slackers. Yeah. And then finally, 2 studies looked at pregnancy complications and did not find any impact on the rate of antepartum hemorrhage, placental abruption, gestational diabetes, gestational hypertension, preeclampsia, or infant admission to the NICU if women are breastfeeding during pregnancy. So this is all very reassuring, except that clearly maternal nutritional status can impact pregnancy health in general. And as I said before, I just generally recommend that if they're eating for 3, that they should probably see a dietitian just to kind of check in, make sure things are okay, and make sure they're taking their prenatal vitamin. And if they need iron, making sure that they're taking their iron.
Yeah, I would say, I wouldn't routinely do any labs, but say take your regular vitamin, make sure you're getting enough calories. And it's always, I think nutritionists are great, helpful to get some insight from somebody who's dedicated their life to that, topic.
Yeah, and I think that in general, OB care is so phenomenal. They're just tracking fetal weight gain, and they're tracking maternal weight gain, and they're generally getting, followed closely. So yeah.
Yeah, that was really interesting and definitely adds to the sparse knowledge that is available on those topics. So thank
Yeah,
you
for
for bringing
sure.
that. I, of course, wanted to talk about Philip Anderson's latest contribution to medications and breastfeeding, which is in the August 2025 Breastfeeding Medicine, and it is titled Antipsychotics and Breastfeeding. Um, he covers all sorts of medications, and I think, this is one that really makes people nervous. So he starts by
Yeah.
saying antipsychotic drugs have long been a concern in nursing mothers, and some new drug classes have become available in recent years. In evaluating the acceptability of antipsychotics during breastfeeding, consider that a relative infant dose of 10% or less is generally thought to be an acceptable amount. However, one expert guideline proposed a safety limit of 5% for psychotropic agents. The column reviews the data available on antipsychotics during breastfeeding. Information on the specific drugs comes from LactMed, the online database that anyone can Google. where more information on the original references can be found. It discusses the literature on transfer of these medications into breast milk and then the impact of the medications on milk production, which is really impactful for a few of these medications. So we're going to go through several generations of agents. First generation agents are antipsychotics that are dopamine D2 receptor antagonists. These encompass phenothiazines, butyrophenones, and thioxanthines, and a few miscellaneous agents. Oh, I'm so glad I signed myself up to pronounce all of these
Yeah.
challenging pharmacokinetic names.
So wait, so before you go on, as dopamine and
Antagonists.
antagonists, right? So they're going to raise prolactin because
Yep.
dopamine is the prolactin inhibiting factor. Yeah,
As opposed to the second generation.
right.
First, we're just going to mention, and I'm going to mention a bunch of different agents briefly, and then we can have, some conversation around the ones that we find most impactful. But chlorpromazine is a classical phenothiazine, and the literature on the use of it in nursing mothers is quite old. Milk and serum infant level data may not be accurate because of that. However, it has been reported to have a low RID of around 2%. Most reports found no detectable drug in infant serum, but it was detected in 2 infants' urine where it may have concentrated. There were a few cases of drowsiness reported, and in some cases, those mothers were also taking other drugs that could cause sedation. And, I sort of wanted to leave in all this detail about this drug that isn't used that often, just to highlight, some of the challenges in reporting on this are really having to do with what is available and the fact that often there are effects of multiple medications, and often these drugs have been taken through the pregnancy as well as during lactation, so it can be really hard to suss out the effects. So other phenothiazines include trifluperazine and perfenazine, which have few reports of milk levels, and those concentrations were quite low to undetectable, with RID estimates less than 1%. A few infants exposed have been reported. One under 2 weeks of age had measurable amounts of serum trifluoperazine, but the mother had been taking it throughout the pregnancy, so the contribution is unknown. Haloperidol is the only butyrophenone in the United States to treat psychiatric conditions, and maternal doses of haloperidol up to 10 milligrams per day produced low levels in the milk of 15 mothers and in their infants' serum. No adverse effects have been reported in breastfed infants when haloperidol was used alone, including limited long-term follow-up data that showed no adverse developmental effects. And I will just say, in some of these, the long-term follow-up was at 6 or 12 months. It wasn't like age 18.
Yeah.
Now we're going to talk about second-generation agents.
Wait, I just want to talk about phenothiazines for a second.
Okay.
So that dates me because these were some of the main antipsychotics that we used early on in my training, and they cause zombieism. I mean, people just did not. It's one thing about the RID and how they transfer into breast milk, et cetera, but these mothers can't function when they're taking this stuff. I mean, they're so drowsy unless, for some people, maybe they're doing okay with schizophrenia, but generally we don't really see these used that much anymore.
No, I
And
agree. And I think it's really helpful to have that perspective because my experience is haloperidol is the thing they give as an injection to knock somebody
right,
out who is
exactly.
out of control and is dangerous.
Exactly. Yeah. And so some of the older studies on inducing lactation from like 1980s, 1970s, 1990s even used chlorpromazine instead of metoclopramide to induce lactation because it raises prolactin so well. It's just like 10 to 25 milligrams, 3 to 4 times a day. And I can imagine what these women are going through, like all of this chlorpromazine, just like so tired and so probably like brain foggish to bring in milk production. Like, man, oh man.
I mean, that's really interesting. And I say that to people a lot of times when we're talking about medications and breastfeeding is, there's a lot of concern about is this going to get to my baby? And I'm like, well, who's going to be there helping take care of your baby? Because you're going to be,
Exactly.
passed out if you're taking X, Y, or Z medication.
Right. Yeah.
All right, so second generation agents, because of the propensity of first generation antipsychotics to cause extrapyramidal side effect or Parkinsonian effects and fatigue, as we were discussing,
Hmm.
prescribing has largely moved to newer second generation or atypical agents. The early second generation antipsychotics are dopamine D2 and serotonin 2A receptor antagonists, so-called 5-HT2A. So clozapine, the first marketed atypical agent, which is virtually free of extrapyramidal effects, but unfortunately can cause agranulocytosis. This adverse effect has caused a decrease in its prescribing, but it is still used with careful monitoring when other agents have failed. It has been measured in the milk of one mother and appeared to have an RID of around 1%, although the timing of sample collection was not described. And I just think this is a really key point because I see it a lot in his writing that, sometimes people are checking these, but there isn't enough known about lactation for people to do a thorough job of getting samples that are appropriately timed and reporting on that. And so, just
Hmm.
something for us to remind people about.
Yeah.
Um, in an infant partially breastfed by a mother taking clozapine during pregnancy and postpartum, the infant's serum levels decreased from 56% of the mother's serum level at birth to 6.5% at 33 hours postpartum. So the exposure in utero is significant.
Yeah.
And follow-up of infants exposed through breast milk found drowsiness in one infant, agranulocytosis in another, and delayed speech in a third. None of these could definitively be pinned to clozapine use, though. And two other infants were breastfed during maternal clozapine use and had no neurodevelopmental disorders at 6 months and 1 year of age. All right, moving on to medications that I actually see my patients using.
I want to wait. Can we step back for a second?
Yeah.
Um, I want to talk about like why people take these, just for
Oh,
people to
oh
know.
yeah.
Yeah.
So, I mean, I will say we're going to touch on this a little bit later, but in theory, these medications are given for psychosis, which
Mhm.
could be from schizophrenia, but can also be associated with bipolar disorder and some other psychiatric disorders. And I think that's really important for people to know because sometimes they are added on to another psychiatric medication. And in addition to that, people with bipolar disorder are sometimes treated with them um, because of depression that is resistant to treatment by other medications.
Right. Yeah, that's where I think I see them the most, other than bipolar disorder, is that treatment-resistant depression.
Well, and I think that sometimes people who have treatment resistant depression have bipolar too, which is a, I would say, milder form of bipolar that is often misdiagnosed or not accurately diagnosed.
It's more common in women too.
Hmm.
Yeah.
Yeah. Um, all right. So olanzapine, which is often under the name brand of Zyprexa, is an early second generation agent that has more extensive breastfeeding data than most other antipsychotics. Maternal doses of olanzapine up to 20 milligrams per day produce low levels in the milk of 25 patients and undetectable levels in the serum of 11 breastfed infants. In all, 151 breastfed infants whose mothers were taking this have been reported in the literature, with a few cases of dose-related infant drowsiness, irritability, tremor, and insomnia reported in the short term. Long-term follow-up found some cases of speech delay, motor development, failure to gain weight, but numerous cases of normal development also. Many of the infants were also exposed in pregnancy, so the adverse effects cannot necessarily be attributed to breastfeeding alone. And systematic reviews of second-generation antipsychotics have concluded that olanzapine is a first-line antipsychotic during breastfeeding. And so to me, this was the headline of this article. A,
Interesting.
a
Yeah.
new olanzapine combination product contains samidorphan, an opioid partial agonist, which has not been studied during breastfeeding. The combination product appears to be acceptable during breastfeeding, but it may cause more drowsiness or respiratory depression than olanzapine alone. All right, next, quetiapine, under the name brand Seroquel. This drug is similarly data-rich compared with other antipsychotics. Maternal doses of up to 400 milligrams per day produced doses in milk that had an RID of less than 1% in 31 patients. Limited long-term follow-up of infants exposed to this found that infants mostly developed normally. Systemic reviews found second-generation antipsychotics have concluded that quetiapine is a first or second choice antipsychotic during breastfeeding. All right, risperidone, Rexulti. Data from 6 women indicate that maternal risperidone doses of up to 6 milligrams per day produce RID of just under 5%. Reports of 4 breastfed infants found no active metabolite was found in 1. Systemic reviews of second-generation antipsychotics conclude that risperidone is a second-line agent during breastfeeding because of the limited data available and higher excretion into milk compared with other drugs. In an interesting case report, a woman in India who was diagnosed with undifferentiated schizophrenia took risperidone 4 to 5 milligrams per day and trihexyphenidyl 2 milligrams through 5 pregnancies, breastfed each infant for 20 to 24 months with no adverse developmental consequences noted in any of the children. At the time of publication, the oldest 3 children, aged 22, 23, and 26 years, had completed their education and were employed, and the youngest 2 were 15 and 19-year-old and doing well academically.
That's so funny. But what was the dose? You said 4 or 5 milligrams a day?
Yeah, it said 4 to
Okay,
5
4 or
because it
5.
was
Okay.
multiple pregnancies. Paliperidone is, or 9-hydroxyrisperidone, is the active metabolite of risperidone, and no studies have measured it in breast milk after administration on its own. In addition, that medication, paliperidone, is available only in a long-acting product. And so as an active metabolite of risperidone, they've estimated an RID of around 1%. The long-acting injectable formulation may continue to deliver small amounts to breast milk for many months. There are 3 additional medications that are similar to risperidone, named lurazidone, lumateperone, and iloperidone, and no data or very limited data is available on their use during lactation. And lastly in this section is ziprasidone, also known as Geodon. In one woman, ziprasidone was started at 9 days postpartum. The dosage was not stated, but presumably started low and titrated up. Maternal serum and milk concentrations were obtained 10 minutes before the morning dose every day for 16 days. By day 7 of therapy, the patient was taking 80 milligrams twice a day, and ziprasidone was not detectable in milk until day 10 of therapy, when the concentration was 11 micrograms per liter, and thereafter the milk concentrations were not quite quantifiable at less than 10 micrograms per liter. And that is the only information that is available on that drug. I will say,
Because I've had patients on it, I guess, getting drug levels is not the easiest thing to do. So,
yeah,
yeah.
absolutely. And it's interesting how they chose to get these levels. This is not generally what the people at the Infant Risk Center suggest when I ask them about a patient. But I will also say that I have seen more than one patient on this medication who had a positive effect on their prolactin and on their
Oh,
milk
yeah. They
production.
make a lot of milk. Yeah.
Yeah.
Yeah. That's one of the
Um,
reasons I like it is because if that's what the psychiatrist chooses, because they can sleep all night and wake up and never have a dent in their production.
well, and that's why, it's fascinating because when you think about those earlier ones and the systemic reviews, and there's, this is a recommended first line because there's all this data, it might not actually be the best one, but is the best that we have data on. And so I'm
Yeah,
like, okay, well, maybe some of our patients, we need to do some more levels.
I think
And
we
we're going to
do.
talk a little more about that in a bit.
Oh,
So
good. Okay.
thank you for bearing with me through all of those. We're almost through all the medicines. So
Okay. I'm
there's
very
a few
impatient.
dopamine agonists. The second generation agents are distinct. These ones are for having a dopamine D2 agonist rather than antagonist property and no effect on serotonin receptors. They include Abilify, Rexulti, and Vraylar. The generics of those are aripiprazole, which has relatively high levels reported in the milk, with RIDs of 8.3% and 12.7% reported in two women. Other reports have found lower amounts in milk. Only one infant has had serum levels reported, a woman who was taking 18 milligrams a day during pregnancy and postpartum. On day 6, her breastfed infant had a serum concentration of 7 micrograms per liter, which is almost 20% of the maternal
And
concentration.
that's aripiprazole you're referring to.
Hmm.
Wow, that's really high because it's such a common medication used during pregnancy
Hmm.
and lactation, unfortunately. Yeah.
Yeah, although we're going to talk about its effects on prolactin later, but I really haven't seen people be successful with breastfeeding while
Yeah.
taking this drug. And so even if the milk levels are really high, it's not very much milk.
Yeah, I don't even know how they get that milk level because there's no milk.
Well, I mean,
I
sometimes there's
mean,
a little bit of
there's a
milk.
little bit of data, but I would never be able to get any milk droplets from someone taking.
Well, and this is the interesting thing also about this, what I just said of this, day 6, her breastfed infant had this high serum concentration. Was that still in part from the pregnancy? Because this does have a long half-life.
Yeah, it takes a
Um,
long time to get out of the system. That's why it takes so long
well,
to
and that
come.
was the last sentence I was going to say was because of the long half-life, the infant serum concentration could have been from transplacental transmission.
Yeah, yeah.
Um, Brexpiprazole, Rexulti. This is another dopamine D2 agonist similar to aripiprazole. Only one mother-infant pair has been reported. A woman with schizophrenia received brexpiprazole 2 milligrams once a day, risperidone 2 milligrams twice a day, and quetiapine 12 milligrams twice a day during pregnancy and postpartum. That was a lot of medication.
Yeah.
And the concentration range from 1 to 6 micrograms per liter at various times. They estimated the RID could be 0.7%. And then later, serum levels declined. It has a half-life of 45.9 hours. By 115 hours postpartum, it was undetectable in the infant serum.
Brexpiprazole can do the same thing as aripiprazole. It can drop
Yeah.
production. Yeah.
Um, and Vraylar, car cariprazine. This is the third dopamine D2 agonist. It has not been well studied, but its active metabolites are 90% protein bound, so it's unlikely that clinically important amounts are excreted into breast milk.
I think that one also someone brought up on our listserv, on the able listserv, that the patient didn't have any milk when she was given that during lactation.
I see.
Yeah.
Um, okay, cholinergic agents. This is the last one. Xanomeline. This is a new cholinergic antipsychotic drug that is available only in combination with anticholinergic drug trospium, which is used to counteract xanomeline's peripheral cholinergic effects. No information is available on the clinical use of this during breastfeeding, but because it is a charged molecule, it is unlikely to pass well into milk. Okay, now we're going to talk about this registry report. So basically, there's a registry called the National Pregnancy Registry for Atypical Antipsychotics. And I was not aware of this before I read this article. The registry was established more than 10 years ago, and all pregnant people, 45 and younger, with a history of psychiatric illness are eligible to enroll in the registry. In case anybody is interested, you can find it by Googling the National Pregnancy Registry for Atypical Antipsychotics.
Oh,
And
interesting.
patients can call toll free to register. The number is 866-961 2388. And I looked at the website briefly. There are more than 14 antipsychotics right now that they are interested in studying. And people who aren't on those medications but have psychiatric illness can register because then they can be used as controls.
Who's
So,
doing the registry? Do you know?
say it again.
Who's doing the registry? Who runs it?
The website is through Harvard and Boston Medical Center.
Oh, okay.
So, in the report that's mentioned in Philip Anderson's article, patients enlisted in the registry were taking a second generation antipsychotic while breastfeeding were compared to control breastfeeding patients, about 600 on the antipsychotic and 800 who were not. And those who weren't had primarily diagnoses of major depressive disorder and anxiety disorders, most often treated with an antidepressant, but not with a second generation antipsychotic. Of the patients who were taking a second generation antipsychotic drug, 60% were on more than one psychotropic agent, compared with 24 among women in the control group. A review of the pediatric medical records found that no adverse effects were noted among infants exposed to second generation antipsychotics as monotherapy or polytherapy. In the article, I'm not going to go into it. There are a couple of additional drugs that are mentioned that are only used outside of the United States. And then we're going to talk about effects of milk production on breastfeeding. Unlike the first generation drugs that increase prolactin, most second generation agents have a minimal effect on maternal serum prolactin levels. However, the dopamine D2 agonists can inhibit the establishment of lactation postpartum. Most cases have been reported with aripiprazole, and a retrospective study of outpatients receiving an average dose of 17 milligrams per day or another antipsychotic found that those receiving aripiprazole had an 81% chance of having hypoprolactinemia compared with 3% in the comparison group. Several case reports have documented decreased lactation in nursing mothers taking aripiprazole, and brexpiprazole has also caused a reduction in milk supply after it was started in a nursing mother. Cariprazine has similar effects, but no human reports are available. Anticholinergic drugs can also reduce serum prolactin in non-nursing women, so there is cause for concern in nursing mothers taking an anticholinergic, such as trihexyphenidyl, with a first-generation antipsychotic to counteract extrapyramidal effects, or trospium, as I had just mentioned before. Although data are not extensive, 2 cases have been reported of mothers successfully breastfeeding using those anticholinergic and a first-generation antipsychotic during 3 and 5 pregnancies, respectively. First-generation agents increase serum prolactin and may counteract the anticholinergic effects. Patients enlisted in the National Registry for Atypical Antipsychotics described above were questioned about breastfeeding. Of the women in a second-generation antipsychotic, 59% reported ever breastfeeding, compared with 88% in the comparison group. And at 3 months postpartum, 23% of women on a second-generation antipsychotic were exclusively breastfeeding, compared with twice as many in the comparison group. So, in summary, second-generation agents are preferred antipsychotic drugs in nursing mothers, with olanzapine and quetiapine having the most safety information available. And many patients take more than one to treat their condition. So the combined effect of all the drugs at various doses on breastfed infants and milk production is hard to predict. With all antipsychotic agents, monitoring the infant for drowsiness, weight gain, tremors, abnormal muscle movements, and developmental milestones is advisable, as we do with all babies, especially if other psychotropics are used concurrently. And antipsychotic use may decrease breastfeeding rate, although it's hard to separate the drug and disease as the cause. Aripiprazole, brexpiprazole, and probably cariprazole lower serum prolactin and can decrease milk or stop milk production in nursing mothers. And I actually strongly believe that aripiprazole should have a black box warning because I have met many patients over my career who have been given this medication during pregnancy, not knowing that it would make it impossible for them to make milk. And I think it's really important here to clarify that it isn't safe to take during pregnancy and then stop for lactation because during pregnancy, that glandular development will not occur if prolactin is suppressed.
Well, that's the question. That's the question that I wanted to bring that up because I do notice that there are some women who did take it throughout their pregnancy, stopped it, and were able to lactate after they stopped it. So now I wonder if that's really true because estrogen and progesterone, may play a greater role. Plus, there is prolactin that comes from the placenta that's not from the pituitary, so it's not going to be inhibited by dopamine. And there's human placental lactogen. So that has been my thought this whole time. But I mean, a lot of these women will say that they have breast development, that their breasts grow. So I wouldn't, I, I would say it's still worth it. It's still worth trying.
Oh, yeah. I'm not saying that it's not worth trying breastfeeding. I'm just saying that in terms of the advice that patients are given about the safety of using it during pregnancy, there is the potential that that could interfere with lactation, in that some people might be told, oh, yeah, go ahead and continue that medication and then stop it when you want to lactate after you
Right,
deliver.
right,
And I
right.
don't think that we know enough to consider that to be safe. But you're right. I think, there's a lot more needed in terms of testing people's prolactin during pregnancy while they're on these medications.
Yeah, I have. I have actually done that during pregnancy, and it's been very low. But nevertheless, sometimes I do see, like I just had a patient recently who was on it during her pregnancy, during the first 2 trimesters. I just saw her for the first time recently, during her first 2 trimesters, and then her doctor contacted me about it, and I said, "Yeah, if you can switch, if you feel like you can switch it." And the doctor said, "Yeah, that's fine." The patient wanted to switch it. And she had high milk production in the past with her other child. And so then when she switched to Zyprexa and has tons of milk. And she stopped it I think toward the end of the second trimester, and we consider breast development sort of complete by 22 weeks. So I don't know. I mean, I think it's something that we have to really learn more about. I agree that that's a reason there should be preconception counseling on these meds for sure.
Yeah,
Uh,
I agree with you. I
yeah,
think there's just a lot that we have left to learn.
yeah, yeah. Yeah, were you going to say something about like if someone wanted to get drug levels done, like how they go about doing that? Because we would love to add more data to what we know, right?
Oh, you mean like if someone is taking care of a patient and they want to do a case report, what the appropriate way to do
Yeah,
drug levels would be?
yeah.
Um, you know what? That's a really interesting question. And I think that it depends upon the medication in question because it somewhat relates to what the half-life of that drug is. And so I usually reach out to Infant Risk Center. So um, I think that I don't know, a lot of research comes out of Infant Risk Center in Texas, which
Mm.
was founded by Dr. Hale, who
Yeah.
has passed along his legacy to some other um, pharmacists now. And so what I find is it's pretty easy to contact them. You can, look up Infant Risk Center online and call the number and say, I have a patient who's taking this medications. Are you guys interested in, analyzing samples, in which case they will work with you to tell the patient how to collect and when to collect. I think even if they aren't necessarily studying that particular medication at the time, they're very helpful. And I would encourage anybody who has a patient like this to reach out to them.
Yeah, they used to have registries like, oh, if you know of anyone who's on this medication, we're trying to, we want people to contact us so we can follow their meds. And so, yeah, I wonder, it seems like because the pharmaceutical companies have been charged with the need to have more data on reporting on medications during pregnancy and lactation, do you think that they would sort of fund that? But yeah, everyone's getting hit financially right now.
Yeah, I don't know what the enforcement arm is of that requirement.
Yeah.
So,
But I think one other thing I wanted to mention in this review that you did, what struck me is that most of these medications really don't go into breast milk very much. Most of these meds, other than perhaps risperidone, are really, the baby's hardly affected. Now, like you said, we're watching babies for side effects. And I think one of the difficulties that I've seen is that sometimes these babies are late preterms or premature and they're sleepy, right? They're sleepy at the breast. It takes them a while to get going with feeding. And then the question always is like, how much of this is the medication? How much isn't? And so that's just kind of a little bit of a dilemma, but I have felt overall that these babies tend to progress in their normal way.
well, I agree. And I would say that another thing that's listed for some of these is abnormal muscle movements. And people ask me about newborns all the time. They have all sorts of little twitches and vibrations and reflexes. And so, it's like when you look at the side effects of any drug online, dry mouth is listed because people have to list every single thing they're experiencing. And
Right.
everybody's got dry mouth at some point. And so that ends up being a really commonly listed side effect. So it's hard to know how much of that is related to just people not recognizing normal newborn
Right.
behavior versus what is
Right.
going on with the drug.
Exactly. Yeah. Well, thanks for covering that. That was a really good conversation.
It was a mouthful.
It was a mouthful. Yeah. Lots of practicing of drug names. I'm so thankful for the common, commercial names that are given because the generics are like impossible. So,
Yeah. It's hard though for patients that many things have multiple names. I mean, my children, the other day I said something about, take an Advil and they were like, this bottle says Motrin. Why are you handing me this? And I'm like, oh, well, that medicine has 3 names for a reason I'm
yeah.
not completely sure of, but
Yeah. All right. Well, thanks, Karen. Another podcast, another month, and I will see you in about 4 weeks.
sounds great.
Right.
Can't wait for the conference.
Yes. Yes. Yeah. Take care. Bye.
Bye-bye.
For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.